Rehab and physical therapy are an essential part of healthcare and recovery. They help restore independence in everyday activities and meaningful life roles. The importance of physical therapy and rehab tonight on Call with the Prairie Doc.
Welcome to On Call with the Prairie Doc. Health information based on science, built on trust. I'm your Prairie Doc guest host, Carter Holm, and tonight we will be talking about the importance of physical therapy and rehab. Physical therapy and rehab are crucial components in the recovery process from illness and injury. These treatments help patients regain strength, flexibility, mobility, while enhancing their overall quality of life. Through targeted exercises and interventions, all types of physical therapists and other healthcare professionals work with patients to address specific areas of weakness, dysfunction, to help them gradually rebuild their physical abilities. Additionally, rehab helps play a critical role in preventing future injuries by teaching patients proper techniques for movement and providing them strategies to improve their overall health and well-being. By promoting healing, supporting recovery, physical therapy and rehab are essential in helping individuals achieve optimal physical function and regain independence. Tonight we'll be discussing the different types of physical therapy and why it is important in our recovery process and recommended by so many doctors. This evening we are joined in the SDPB Black Hills studio by April McNaboe, a physical therapist from Black Hills Orthopedic and Spine Center, and Laura Bosness from About You Physical Therapy, Rapid City. We are here to answer your questions this evening about the importance of physical therapy and rehab. Welcome. And thank you so much for joining us this evening.
Thank you.
Thank you.
So, April, before we begin and delve into our discussion, could you please share a bit about what your background was and what inspired you to go into therapy?
My background is, well, for one, I was an athlete in high school. I got injured, had to go to physical therapy. So that was my first experience with that, and I was interested in it ever since. But otherwise, my background has been primarily outpatient orthopedic and sports medicine. I specialize in a lot of spinal rehab and issues such as osteoporosis and scoliosis. I'm also an OSHA certified specialist in ergonomics.
Okay.
Yeah.
Working in the workplace. Okay.
Yes.
And Laura, can you tell us a little bit about your background and what brought you to working in physical therapy?
Sure. So same idea, athlete in high school and had an injury, that was the first. And then I saw a program actually about children in physical therapy. And so that in high school kind of drove me into PT. I've been a physical therapist for 30 years. And although I specialize, I would say, in orthopedics, outpatient orthopedics, the first 2 years of my career, really noticed that chronic pain was a large problem, right? But also how the brain works and drives that neurologic system. So in studying the body, I really also began studying the brain. And so, because it's really the brain that runs that muscular system that makes all things move. And so that's also a piece in just studying how the human design works.
Let's follow right up. My first question was actually, what is the role in physical therapy in managing chronic pain?
Right. So with chronic pain, you really have to look at the whole person, right? Because you're going to start expressing mental and emotional, and what you start believing leads to your thoughts, your actions, and pretty soon really the results you start seeing. But really getting people on track to understanding with education. And you don't use the philosophy of no pain, no gain, but also you don't use a philosophy of if it hurts, don't do it.
Right.
So teaching them and educating that happy medium. Right.
Yeah.
Right. And so when they learn that, and just getting them back to moving from not just feeling like you're surviving, but actually back to thriving and enjoying life and a quality of life.
And I think part of that too is, showing them how they can adapt their daily life and change things through that they're currently doing that can help them furthermore function, enjoy what they're doing, but definitely making those adaptations and changing a few of their current lifestyle things that they're doing.
I see in my area of inpatient rehab, adaptation is crucial. And if you're talking about a stroke patient, you're going to have to learn a lot of adaptations. But can we talk about maybe what adaptations you utilize to help improve a patient's mobility and their ability to move?
Mm-hmm. I am a firm believer in the no sitting protocol. I've seen it work so well. You'll get a patient who's had chronic spine pain, back pain, neck pain, whatever it may be. One of my favorite questions to ask a patient is, what's a typical day for you?
Right.
And I just start writing, what do you do from the time you get up until you go to bed at night? And I write and write, and I really listen to what they're currently doing all day long. And then I say, you're sitting, you're sitting, you're sitting, you're sitting, you're sitting.
Yeah.
You're not moving well. The reason you're here is because you can't move from point A to point B any longer. That's
right.
why you're at the doctor. That's why you're seeing me. Mm-hmm. What happens if we try to get you up and moving? And then pull out a chart and really show them what those kind of forces do to compression of your spine that causes and creates pain versus standing forces, which are much
right.
better, more improved. And then all of a sudden, they're not standing for just 5 minutes at one time before they have to sit in a chair to rest their spine, which is truly making it worse, but rather they're now standing and walking for 10 to 15 minutes at a time, but maybe lying down or reclining for 5 minutes before they get up again and try moving. And all of a sudden we see their chronic pain and their issues start to decrease because of improved movement. So that's one of the strategies I'll use.
Following up on that, building that tolerance in a patient who maybe hasn't done much exercise, what are some techniques to help get past that, maybe that mental barrier?
Right. So I call it graded motor pacing. And so the education is, how much can you do without pain?
Sure.
So that's your baseline. So let's say that's 3 minutes. And if that's 3 minutes of walking, if you can walk 5 days a week and even only add 30 seconds or a minute, which seems like no big deal, right?
Right.
But by the end of a month, you've added that up to almost 20 minutes. And most people's goal is a 30 to 40. And so kind of finding that happy medium and again going, I'd write it down. Right? Like, okay, today I'm supposed to do 12 minutes, but if I feel great, don't just go walking 20 because you want pain to go down and function to go up, and you don't want to.
You don't want to overdo
right.
it. You gotta stick into that sweet
right.
spot. On my unit, we have a physical therapist named Chris, and her nickname is Sarge because she likes to push patients. Where do you find that sometimes it's good to push a patient and sometimes you maybe need to tone that back?
Mm-hmm. I think anytime you start pushing someone out of their comfort zone, there's a little pushback.
Yeah.
But when you show them, when they think in their mind, they literally cannot do this. They have never tried this stretch before. They've never tried this position before. And you push them to that because they have to, because they're listening to you, and they call me the drill sergeant with a smile.
Okay.
So if you do that and you push them to their comfort level, through their comfort level, they realize they can do it. And then they just, that's a success for them.
Yeah.
So, yeah.
Laura, can you talk to us a little bit about how physical therapy helps prevent injury and promote like an overall wellness?
Right. So, yeah, if it was up to me, I'd have everybody over age 12 start doing a screening where you really look at how all parts move. So pelvis, hip, rib cage, because all of these things, your extremities attach off of there. And how a person moves can lead to injury or not. So it's about that age when they start loading up with sports, weight training, and other. And so wanting to have that foundation that can reciprocate, meaning my rib cage moves, my pelvis is properly moving. Repeat the question again, so I want to make sure I finish that answer.
Well, it actually follows into my next, but promoting overall wellness, and then what are the benefits for athletes?
And so the prevention is, if you don't go into that moving well with proper postures, ergonomics, and a body that can actually move well, as you load that up with speed and weight, you actually increase your risk of injury. So prevention is really the key, because when you're doing advanced training, you're doing it to be on the playing field, right? To be out there running. And sometimes when you're doing that extra training and it's on top of something that's not moving well, it can actually lead to some of that injury.
You said you would love to start at age 12, but what are some physical therapy modules that can help with younger people, with children? Or do we see any children in therapy?
Sure. Like I said, I'm now certified level 1 in the Schroth method for treating scoliosis, and to catch those curvatures that are occurring in the younger population. We'll see that juvenile scoliosis morphing into adolescent. That can be become quite severe, where there's bracing, surgical intervention. So I think those screenings, I think that needs to there needs to be more emphasis on that at the schools, with screenings for these kids for scoliosis. And again, that goes in line with what Laura was talking about, pelvic alignment and everything we're seeing. We can catch a lot of different things that are going on if those screenings are taking place appropriately. Unfortunately, not all kids do well checks at their pediatrician, and that gets missed a lot. So if we don't rely on the school system to actually assist in that, there's a lot of kids that get missed. So I think that would be one area where we could hone in and really focus on some preventative measures moving forward and get these kids treated appropriately at a very young age.
So the prevention, the helping with proper ergonomics in the athletes. What about physical therapy for the older population?
Right. So that's, a huge part of our audience, right? Because as you get older, you tend to lose mobility, strength, balance. And so, really anybody over age 60 or those in our 50s, assessing balance and mobility and strength is a key. And so that we see a lot of those folks. And same with the younger folks. You still need to do what I would call a pattern check. And with those 12 and up, with the older folks, you're also doing, you can even, at some point I'll give you a link or something that you can use. It's a quick pattern checks that we'd like to even teach parents so that they can look at specific patterns and go, oh, I do see that. There's some asymmetries there that are existing.
So we've talked about maybe these general populations, but what about specifically after a surgery or maybe like a traumatic injury? What sort of rehab or physical therapy do you guys do in a post-surgical instance?
I think we're both very versed in that. I know, anything that comes along is lack of mobility, and you deal with post-surgical swelling, incisions. We definitely are probably sometimes one of the first ones to recheck those kinds of things, looking for infection even. And luckily, I work in an environment where I have great resources to be able to bounce those things off of others. But definitely assessing range of motion of wherever it is they had surgery on. As well as endurance. What are they doing at home? Really assessing how are they getting around at home now? What's the situation there? Again, looking at this holistic picture of what is truly happening with this individual at home, getting to rehab. Are they able to drive? Are they not be able to drive? I feel like we're always the liaisons between the patient and the physician sometimes when it comes to those situations. So.
Yeah, and if I can add to that, for
please.
I think you asked the post-surgical and acute injury. For the folks watching, just as something for themselves, if they have swelling, initially it should be elevation and ice, right?
Right.
Post-surgical.
Yeah.
And then the importance of, as April was saying, getting the range of motion and getting them back to trying to walk as normal as possible, even if it's with crutches or otherwise, but a normal gait pattern so they're not developing poor patterns that again can lead to more injury. So that initial decrease the swelling, increase the range of motion, work on the gait, meaning the walking.
Yeah.
It's very common that patients want to get rid of their assistive device right away, whether it's a walker, a crutches, cane. But I'm a firm believer that, you know, if you are limping without anything, but I put a cane or one crutch in your hand and you smooth out your walking, you don't want to form bad habits. So naturally, we want to keep you on that assistive device until you've gained strength and mobility and endurance enough to when we do want to try to wean from that, you're walking very well, you know, at that point. So try to talk that patient into that is sometimes difficult, but I think it just, you know, if you can, and they are very receptive to it most often, so they understand that concept. You don't want to form bad habits with that gait pattern.
Perfect. Thank you.
Yeah.
There is a wide range of complications from stroke. There's also a wide range in how well each person recovers afterwards. Researchers have found that people who participate in a focused stroke rehab program perform better than most who don't have stroke rehabilitation. I had the pleasure of sitting down and speaking with the Avera Health physical therapist, Michelle Berkst, about the stroke rehab process and how it helps patients get back to their daily activities of daily living. So today we kind of wanted to focus a little bit more on stroke rehabilitation. Can you tell us just a little bit about a baseline care for a stroke patient?
One of the complex things about stroke patients is that they're all different. Every single stroke affects every single patient differently. And so our job as physical therapists is to be movement experts and identify where their limitations are and their impairments. And then our job is to help increase their independence, improve their safety, and maximize their quality of life and self-reliance.
Are there any areas that you focus on that really could be for any stroke patient?
A big thing that physical therapists work on is generally walking. Almost every patient who's had a stroke, if you ask them, they want to walk better, they want to walk normal again. So we almost always work on walking. And with that comes balance.
Yeah.
Every patient needs to work on balance, whether that's sitting balance so they don't fall off the bed while they're putting on their shoes, or not falling when they're walking across their kitchen. I just try to take every patient and work on them with their specific interest and try to make that important to them, because that's important to me, because if they're more interested in performing a certain skill or a certain task, they're going to get more benefit out of it.
Might not see it as exercise.
Yes, then it's more fun. And if we can make therapy fun, everybody's happier.
Yeah. Next, I was kind of curious if you could tell us a little bit about the transition from the inpatient side of the therapy to an outpatient.
In inpatient rehab, we had short-term goals, be able to stand, be able to dress, be able to walk or move safely throughout our home. In outpatient, they can work on those long-term goals, get back to golfing, go hiking or hunting or whatever that person might enjoy.
What encouragement would you give to viewers at home who have maybe had a stroke in the past and are still working to get back?
There's always more room for improvement. Years ago in healthcare, we thought that people who'd had a stroke had a year to recover, and then they were stuck there.
Right.
That's as good as it's going to get. And that's not true. We're learning more about the brain, we're learning more about the body, and we're learning that we're never done improving. Our brains are always able to learn more, and our bodies are always able to keep trying new things if you put in the work.
Welcome back. How quickly can we begin with that physical therapy following a stroke? And how quickly do we see that transition from the inpatient rehab to seeing you guys in an outpatient scenario?
So I'll take that one. We both do outpatient physical therapy, but they generally see them very early on. When I worked in a hospital setting my first 2 years, you were oftentimes seeing people in ICU.
Sure.
So that's very quick. And in terms of when we typically see patient and outpatient, I'd say the minimum is 3 months, but it's because they've been doing 3 months of an inpatient or a skilled nursing. The ones I'm seeing right now, for instance, it's been 10 plus years, but other things are going on. You're still human, right?
Yeah.
So you might develop back pain or more of a stiffness in a shoulder. So it's really then looking at the whole person's movement and getting them strategies that maybe they forgot from 10 years earlier when they were in rehab, but also just looking at them again as to the side that also works, right? There tends to be a forget that this person still has to reciprocate right, left, and that side also needs work.
So maybe the inpatient team worked really hard to get this person safe to go home, but maybe when they're home, that's not quite where they're finished with their story. Do we see therapy helping patients in that first year following a stroke, or do you guys mainly see it if it's following maybe a secondary issue or like a gait instability that continues?
I think definitely we can see them right away. I mean, I've had that as well, because although they're safe at home, they still haven't really met those goals that they want to achieve. You know, they were safe, they got discharged from the hospital, but they still have goals, and they're still not moving as well as they should, but they do qualify for outpatient therapy. And so there we set goals with them, and then start working on, again, the overall picture, their whole self, and working on that, improving their endurance, their gait, just strengthening bilaterally, like Laura was saying. You know, it's hard to stay up.
Cars, is that something that?
Yes, yeah.
Being able to interact with the grandkids, is that? Can you tell me more?
Because the first 6 months after a stroke is when you get the most spontaneous recovery.
Sure.
But that still occurs, I think textbooks would say up to 2 years, but really even beyond, right? And yes, the goals will change. Initially, it may be getting in and out of cars, getting dressed oneself, then it's getting on and off the floor, playing with the grandkids. And for some folks, it may be, hey, now I want to hike up this mile hill to go to my granddaughter's wedding.
Working in the hospital, when my physical therapist asks my patient to get on the ground, I'm like, what are you doing? We don't want people on the ground, but we want them to be able to get up if they've been down playing with their dog or playing with their grandchild. So I can see there are definitely some specific differences in that inpatient setting that I'm so familiar with to seeing those long-term goals. My next question is maybe in a similar vein to the stroke, but what are some physical therapy management issues for other neurological conditions? Maybe a patient who has MS, or any other specific neurological conditions that you guys take care of?
And I think we do take care of that. Even, you know, brain injury at times. You know, definitely people have lots of different issues. And again, it's about assessing, you know, what are their functions now? What do they want to get to? If it's simply standing, walking for a while, then we start working on that and working on strengthening, core strengthening even. I mean, that's the basis of the strength of your upper extremities, lower extremities, is your core strength. So, you know, that's very important to consider when working with someone. And I don't know if you have anything
Parkinson's is another neurologic condition, and actually highly seen in the Black Hills. And Same idea, you're looking at balance, mobility, function, quality of life, but progressing from an individual program in PT and home program into community-based activities. So like we offer, it's called Rock Steady Boxing. And I would ask any geriatric 60 and older to come watch them because it's very inspirational to watch that group do that program. It's highly dynamic, fun, and a lot of social activity as well, but they literally are boxing and dribbling basketballs and all kinds of...
Making exercise fun. Yeah.
And then introducing them to other things like walking poles, you know, making them, finding that inner athlete in them again. You know, they're like, oh, I can only walk so far, I'm shuffling, I might fall, but maybe walking poles. And, you know, that's kind of a big thing too. And Parkinson's, certainly those patients are wonderful candidates for that as well as MS. It's bilateral, it's a little better than a cane that's one-sided. Again, they feel a little more athletic using them. They feel like they can get out, they're more balanced, can actually improve strength and postural muscles when you're using them. So there's a lot of devices too that we can show patients that they probably weren't even aware of that are out there to help them and assist them in getting back up and moving a little better.
Now, in speaking to two former high school athletes, can you talk about maybe that competitive nature? Because I have definitely seen when you can get that spark, sometimes it really helps to ignite something.
Right. And I think at every age, I think it's called kind of the ageless athlete at any age. Everybody has that, and it's really a matter of listening to the goals, like where are they now, and you know, they want their life back. They want those things they enjoyed, and you know, it might be that, matter of fact, one of my Parkinson's patients was in the Senior Olympics for tennis.
Oh, wow.
And so just fun, and then also for ping pong, and then later to pickleball. So there's transitions of maybe you're moving from, you know, tennis to pickleball. Both are a lot of fun.
So moving on from the neurological conditions, how does physical therapy help improve patients who have maybe had some cardiovascular health issues? Do you see people in a cardiac rehab type of scenario?
I don't particularly, but I think it's something we're aware of. You know, certainly I've taken blood pressures and pulse rate, heart rate, you know, for patients who may seem as if they're having some symptoms. We have to be very aware that that could be something happening to our patient at the time. I've done the Harvard step test to test someone's cardiovascular system after POTS or some other kind of cardiovascular episode or condition. And so, you know, you have to definitely be aware, and then work on trying to improve that with them with endurance and you know, strategies to improve their heart rate, blood pressure, that kind of thing. I think that's a huge role for physical therapists.
Yeah.
Improving that wellness to maybe get past some of those cardiovascular.
Right.
Yeah.
What about patients who are maybe experiencing like arthritis or joint pain?
Right. So, of course, itis meaning inflammation, arthro meaning of the joint. And I'm going to kind of harp on this because I've said it a few times, but it's really the muscles that control the bones and joints, and it's the brain that tells the muscles to tell the bones what to do. And so in protecting those joints, you've got to look at the movement pattern, and are those muscles excessively on and causing compression to the joint? Or are they giving the right amount stability? Or are they over flexible and too lax and not giving enough support for the joint? So really looking at how is that neuromuscular system controlling the bones and joints. So even though you frequently hear people say, oh, I've got arthritis, so I'm just going to have pain. And you can, but that's not necessarily true.
I can't use my hands very well because I have arthritis. Are there some exercises that you promote for more fine motor movement? Or is that something you defer to occupational therapy?
Well, when you're talking extremities, I mean, I think no matter what, generally you're looking at, again, at that whole person and what they can and can't do, and we certainly will help with anything we can. When it comes to fine motor, if they're having a hard time using their hands and grasping, I mean, I think that's a little bigger problem than probably what an outpatient physical therapist could probably deal with alone, but then, you know, reaching out to other, again, I always feel like we're a liaison between different entities, and we're always, you know, communicating with other medical professionals on this patient to get the best care that they possibly could have and need, you know.
So, having worked in this field for a long time, I maybe sometimes forget that our audience might not know the specifics. What differentiates a physical therapist from an occupational therapist, from a speech therapist? Can you tell me?
Right. So it can vary. A lot of times occupational therapists, a couple of different things. They might specialize only in hands, or they might do more of what you were saying, the fine motor, like after a stroke, how to, you know, do your buttons and your zippers. I would say physical therapists really look at the whole system. They still can do fine motor, like with Parkinson's. Handwriting often becomes very small, so there are activities we do with the hands.
Yeah, I specifically had a patient who had COVID and actually did have some issues neurologically. I actually ended up calling a speech therapist to refer her to, and that was a blessing in disguise. She ended up going, and she now cognitively is so much better. So a speech pathologist can do many things, work with children on their speech issues, but also cognitive issues for someone like that. And so that was actually a more recent event. I just think in occupational therapy, you know, boy, we rely heavily on them to work on, you know, this patient or pediatric patient to be able to do the things they need to do to take care of themselves at home, right? Besides everything else, joint function, muscle function, endurance, balance training. So
what are some more specific, we've kind of been going over, but if we're trying to improve flexibility and range of motion, what are some exercises that you guys recommend that maybe our audience at home could participate in?
It's a loaded question.
Well, and I think, you know, there's general stretching that I'm going to say you could look it up, right? You know, I have back pain, lay on my back, do my knee to chest stretch, stretch my hamstrings. But I don't like to do the specifics, as you said, because as you look at each person, you really got to look at why is it appearing to look tight. And in that, sometimes you're inhibiting what the muscle is doing. A lot of it, in what I'm seeing, is I do a lot of, I'm going to say, neural respiration as well, because when you have pain, you move different. You breathe different. And so even working on deep breathing and various, it also decreases your neuromuscular tension. And so breathing is a part of if you're doing stretching, relaxation exercises. But if a person's looking for even just general stretching, you can find a fair amount of that really on the internet, honestly.
But with that, I mean, there are some, you know, cautionary tales. As a you know, certified in the Meeks method for treating osteoporosis and safe prescription of exercises for patients with osteoporosis. I mean, there are studies out there that show, you know, a flexion-based exercise program that postmenopausal women were put on caused fractures, spinal fractures, in over 60% of them.
Oh my goodness.
So I'm very leery to just, you know, say, hey, go do whatever exercise. There's many times I see these men and women, young, older, it doesn't matter. It affects all ages and all genders. And you really need to be careful because that might not be the appropriate exercise for them. And so to screen that is really important. So yeah, I'm a little leery with saying, hey, do whatever you want, but if you have questions, I guess maybe seek out a specialist and seek out, maybe you just want one-time visit to get yourself on a good program, and we can assess and see where your dysfunction is, maybe your deficits, and then definitely put you on a nice program that we think would benefit you.
Right.
So.
And I think anytime you're having pain, if you're having pain or you have a diagnosis or an issue, that would not be the time to go on the internet and look that up, right?
But
definitely seek someone out.
Yeah, but a lot of people do, yeah.
Physical therapists are specialists skilled and educated in proper rehabilitation methods. They're knowledgeable about surgical procedures, treatment goals, and work closely with your referring physician in order to develop individualized rehabilitation programs. So why is it hard for patients not to follow through with these treatments? Prairie Doc reporter Sam Schauer spoke with physical therapists who share why completing their prescribed physical therapy is so important for your health and recovery.
Chuck McCullough is a physical therapist for Avera Health in Brookings. He helps patients with physical rehabilitation so they can achieve their movement goals.
Now that can mean so many things. It can mean getting back to sports, getting back to work. It can mean just, I want to be able to walk. Or maybe a new mom wants to be able to hold that baby. So it is very individualized to each person to what that highest level of function is.
McCullough says it is crucial for physicians and physical therapists to know their patients and what they want to accomplish. Knowing what a patient's goals are can make the physical rehab journey go smoother.
Maybe it is walking. Maybe it is, I really want to be able to stand in that kitchen and make some cookies. And if that's their primary focus, I find that if I focus on that primary desire of theirs, I have much better outcomes and have much better compliance to doing their exercises at home and to coming to therapy.
Patients who don't actively participate in rehab exercises are at risk of regression, stressing the importance of physical therapy.
It's my job as a therapist to find that thing that helps them get back to that program and find that motivation. And sometimes it's just sitting down and talking to that person.
McCullough says he assigns a patient 2 to 3 exercises for rehab. If they're excelling at the exercises and reaching their goals, the rehab times are shorter.
Maybe they meet that goal of walking and they think, well, geez, I'm improving, so let's do a new goal. Maybe they have a new goal they want to get so they can get strong enough to go see their grandkid play football and walk into that football stadium without any help.
McCullough says there's no shame if a patient stops doing their exercises. However, if pain reappears, it's important to call a physical therapist and start a new program to mitigate pain and start achieving new rehab goals.
Going back to the therapist is very important, and contacting that therapist, get a hold of them, let them know, hey, I need some help with my exercise program you gave me. Then that therapist can sit down with them and restart and reset their exercise activity, whether it's new exercises or maybe just a refresher of their old ones.
So how long, and this is a general question, how long do you generally see a patient in physical therapy?
Well, I'm gonna start kind of broad because oftentimes when someone shows up, they start because of pain, but there's a whole lot that went on before pain started.
Sure.
And the first thing to usually get rid of is pain, but you haven't really addressed the full pattern of problem.
Right.
So I would say,
work,
everybody would like to be done in 3, but the reality is if you really want to get that to the point of get your life back, if it's a post-surgical, like a total knee, you're probably seeing them 6 weeks, maybe 8. Total hip, sometimes less than that. A rotator cuff surgery is going to be 3 months, maybe 4 months. But I'm going to say on average, 12, but what I think people ought to be seeing is probably 24 to 30 if they really want to hit, depending on what they have going on, because you're usually not dealing with a problem that's just a knee.
Yeah.
You look back and they've had a history of 15 years of back pain, and they've had a shoulder, and they've had a car wreck, and all of those things where you're looking at the whole pattern. So my ideal would be 24, or, you know.
Weeks.
No, 24 visits, 24 to 30, and that would really get on top of things. But I would say on average, you're probably seeing patients post-surgically as those dates, those time frames I kind of said. But I'm going to say more often than not, because you've gotten rid of pain, they're like, oh, I'm great, and I'm good to go.
I'm ready to be done now.
And a lot of times that can be 8 to 12 visits.
Yeah.
We've discussed a little bit about trying to ignite that competitive goal. What are some other ways that we can improve compliance if a patient maybe doesn't want to go through the full time allotted?
So, you know, I always ask them, well, you went to the massage therapist, you went to the chiropractor, you went to the surgeon, you've had MRIs, now you're at physical therapy. What is it that you really truly are wanting here besides you want less pain?
Right.
It could be a chronic pain issue where you have to explain to them, you know, we're probably never going to totally get rid of your pain, but let me focus on how this fluctuates throughout the day. What makes it better? What makes it worse? Really, you know, teach that patient those tools to manage that. Mm-hmm. And so, what was the question again? Sorry.
Well, no, just individualized for compliance.
For compliance,
when you're trying
to
make
so then when
sure
we're trying to, show them what can give them less pain, and that's a tool and a management tool for them at home. You know, I say this might be the only way that you are going to be able to manage your pain moving forward if you don't want surgery. Maybe they've tried injections even, say, into their spine or whatever it may be, hips, you know, whatever. And, you know, those are short-lived, but we find other tools, stretches, exercises, kind of the limited sitting maybe helps with their pain. And now they get a stand-up workstation or something like that to stand a little longer at work. Those are tools. And if their pain goes down and they realize that they've made these modifications throughout the day, they tend to be way more compliant, knowing that that's going to help them minimize that discomfort. So,
do you also find that an individualized plan of action is that your strategy when you have a patient?
Because you really get to know your patients, and each story is different, and so you kind of outline what are their goals. And in terms of achieving those goals, you kind of have to have the talk of, you know, I'm all in to get you to here. Mm-hmm. Are you all in?
Yeah.
Are you in 50%, 70%? Because we're not going to get very far if all of the team is only 50 to 70%. And so when you kind of have those discussions and you're talking about getting your life back and, you know, the joy to move with freedom and strength, they start to see it when you can kind of outline, I see you've seen, you know, 4 doctors and 2 surgeries and a massage therapist and chiropractic. This time, can we treat that whole package?
Yeah.
In that same vein, if we're dealing with a patient who's maybe experiencing more anxiety or more stress, how does that affect how you deal with that particular case?
Again, if you tell them, if you move more and you're doing the things and you get back to doing the things you love with less pain, obviously that's something that's going to, you know, decrease depression and anxiety and stress in them. I think pointing that out when they are successful one day, they come in, hey, I had less pain and I did my exercises every day. Okay, well, let's talk about how that affected you overall. So.
Right. And education is definitely a key. Neuroplasticity is how your brain changes without you knowing it, and helping them find what are those triggers, what is causing that anxiety, and when they can name it, you can now start to deal with it, or you can start naming those triggers of, what's doing that, because when you trigger anxiety or worry, you're also you're triggering an increased muscular tension response.
Yeah.
And so helping them to recognize the triggers, and again, I'm going to go back to a little bit of breathing, because you're going to even breathe different, and 3 deep breaths several times a day can.
That was my next question.
Yeah.
How does physical therapy manage stress and anxiety?
Well, I think going back again, just improved movement, improved quality of life.
Yeah.
Ultimately, they're able to take that trip to see their grandkid, or whatever it may be. When they're able to do those things because they're functioning so much better and they have less pain, they're less apt to have kind of that stress and depression and anxiety that goes along with their pain. Their pain, and which can cause an increase in blood pressure, which can cause, it goes on and on. It's just this vicious circle.
Cycling back.
Yeah.
And of course, with exercise comes endorphins, like your body's natural chemicals, right? So when you can get moving well, so you can move often, exercise is just going to make you feel better, especially and get somebody to go, hey, maybe let's get out of your 10 by 10 room and do a little something at a park. Because sometimes now you've seen a bird and a friend in green grass, and you've had a brain triumph because you got out of the house and you relieved anxiety and stress. Sometimes just getting out of that.
One of my coworkers, Becca, always says, Carter, why don't our patients ask for pain medicine after physical therapy? It's because they've got those good exercise endorphins. I think that is often something that people forget about when they are about to start exercising.
Well, I think, you said that there's this fear factor that when you go to physical therapy, we're going to cause pain. I tell my patients, other than if you're post-surgical, we're there to help you feel better when you leave here. You might be muscle sore, but there's a difference between discomfort and pain, soreness and pain. And really, I really talk to my patients about those differences because there is definitely a fear factor across the board of people going to physical therapy. Oftentimes, even my post-surgical patients feel a little better upon leaving. But, they have to deal with the surgical pain of it and the incisional pain and things like that. But to bust through that fear factor, that's huge.
Now, I think this is a really interesting question. Does physical therapy, do you think, improve a patient's self-esteem or confidence? And if so, how?
I'd say yes, because again, that's kind of looking at that whole human design. And once they achieve something they thought they couldn't. So even in that first scenario earlier in the questions, moving patients from here to there in their progression, as they meet short-term goals and now they're starting to actually enjoy things with the grandkids or golfing or walks in the park, you generally are just going to feel different because of the endorphins, the chemicals, the neurotransmitters that occur in your brain when you're now doing things you love to do.
And more specifically, I think of the adolescent scoliosis patients I see on a day-to-day basis. And, their dance instructor noticed they were a little bit, off or lopsided, or things weren't aligned quite well. And when you can help them and teach them how to get that realignment back, that neutral spine, the positioning, generally, they're so much happier. That's where I really see a lot of improvement in self-esteem in the kids, especially the adolescents, young adults.
Does that connect, do you think, with improving a patient's endurance, improving their stamina, helping build that overall well-being? Breaking through some of that anxiety and improving confidence. Is that? I'm kind of trying to put all these pieces together, and it seems
when you're moving with improved ease, you're already going to feel better. And as April was saying, as you make those achievements in posture and alignment, and people are commenting.
Yeah, that's the key. Then people say, wow, you're a lot taller and straighter.
Yeah.
You know, maybe I have an osteoporosis patient that is a little bit kyphotic and rounded, and you know, then they're like, yeah, they noticed I was really walking really tall, and you know, and so they hear it from other people then, and then that just builds on their self-esteem.
To see the progress, and on the inpatient side, when they come to me, they're maybe coming in a stretcher or pushed in a wheelchair, and then to see that progress to their walking off of our facility, and maybe all they need is a cane or a walker. And then in the outpatient, maybe they go from that cane or that walker to graduating to being able to walk without assistive devices. I mean, do you see that uplifting side in your practice?
Absolutely, yeah.
Right.
Nearly every day, as we see progression.
And as much for the therapist as the patient.
Yeah. I was going to say,
Right?
makes us
It's very
happy.
fulfilling to have people achieve goals and get their life back.
Yeah.
So the significance of physical therapy in managing age-related decline. Now, inevitably, as we age, we're going to lose some of our health and strength. But what are some methods, or what do you see in helping mitigate some of that decline?
Well, I think previously April touched on a sedentary lifestyle. If you're doing a lot of sitting, as soon as you just get people even starting to progress movement, a little bit of movement throughout the day, because it is, I hate to say it, but it is a little bit of a use it or lose it. If you're doing nothing, you're going to get weaker, you're going to lose balance and strength, and when you're staying active, you're going to maintain, and as you progress with your therapy and how you're moving, your strength, your balance, your stamina, your endurance, all of those things do improve.
Yeah. I mean, there's a lot of patients, I mean, posturally, it's affecting their shoulder mobility even, where, you know, I always say reaching into the cupboard to get a glass sometimes is like an athletic event for these people, you know? So, you know, improving and seeing their posture improve, and then getting range of motion back, and they can actually do more, and they know they can do more around even their home or whatever it may be. I mean, I think that's key, is keeping them mobile, keeping them home. We all want to keep them home in their own homes. We don't want them to, you know, lose it so much that they have to eventually go to a facility. So I think that is definitely one of the main goals I have with some of my elderly patients, is making sure they stay in their home.
Yeah. My last question, and it's just kind of to culminate all of this, the overall quality of life. How does physical therapy help to improve that overall mental and emotional well-being?
It kind of wraps up everything we've been talking about. If you're able to do the things as long as you can do them, right? And that's where physical therapy is able to help you see, where aren't you moving well with posture, where aren't you moving in a specific segment, and as you progress that, you're also then progressing into goals, their life goals, right? Their individual goals. And that is really what it is with physical therapy. It is maintaining ability to move well and a quality to life, to do the stuff you love to do. I know I've said that several times, but
that's,
you know,
just a perfect.
If you have a patient who now never goes shopping at, you know, I don't say just Walmart, where they can have a cart and they can go for an hour, but you put them in a JCPenney and now they can only walk 5 minutes. You know, I ask those tough questions on them. What do you want to do? And they're sad because they couldn't go with their daughter or whatever to go shopping. And like, well, we got you a walker, you know, and that allowed you to walk further. Isn't that better than not doing it at all? So it's really listening to the patient and what they enjoy doing and what they want to do, and making those adaptations for them, and teaching them that there's other things they can do to keep moving and keep doing the things they love.
Thank you so much. And we'll be right back after this.
Grab a copy of your local newspaper or read online the Prairie Doc Perspective, a weekly health and medical column. Head to prairiedoc.org to access all archived columns today.
Thank you to our guests, Laura and April, for volunteering their time to help us learn more about the importance of physical therapy. If you would like to see and hear more episodes of this program, please like and follow us on Facebook, Instagram, YouTube, and TikTok, or visit us at prairiedoc.org. Look for Prairie Doc perspectives in your local newspaper and online. Listen to us on Prairie Doc Radio, and be sure to look for us on the podcast network of your choosing, Prairie Doc On Call, wherever podcasts can be found. From all of us here at On Call with the Prairie Doc, thanks for joining us for another episode of health information based on science, built on trust. Until next time, stay healthy out there, people.
My name is Dr. Tom Dean, and I serve on the Healing Words Foundation Board, the nonprofit organization that runs Prairie Doc programming. Our mission is to enhance health and diminish suffering by communicating useful, science-based information respectfully and compassionately. Your donation supporting Prairie Doc programming makes an extraordinary difference. Gifts of any size enhance its impact in our state and beyond. Thank you for your generosity.
Major funding for On Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you, with care and coverage. Hello possibility. Hello healthy. Hello life. Avera, moving health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions, Brookings Health System, South Dakota Academy of Family Physicians, Ophthalmology Limited, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health,